Hello, my dear future nursing officers. I welcome you all once again back to the Master Nursing classes. In this very important, beautiful session, we are going to deal and discuss the most important and the most authentic questions, concept, and the golden points that is much necessary for our future nursing exams. And I want every one of you to stay connected till the end of the video and completely be engaged in the comment section. So I am going to keep this class completely engaged, and in between, I am going to ask few very important one-liners. Also try to respond that every one-liners which I am going to ask to you all. Okay? Yes. So this class is the most important. Don't miss a single point from this one. And immediately after the class, kindly revise the notes which I am providing in the plan A1, A2. Okay? And don't miss any super 60 test, so that is especially designed for the better and the best and the high ranks, right? Yes. And the high yield topics mini test, the topic wise test which we have given, so that is the game changer. At least who all are recently purchased the plan A1, A2, at least you people attend the high yield topics MCQs. That is much necessary for you guys. Okay? Yes. So let's begin the session without wasting a time here. Right, a good evening, and a very good evening. I welcome you all once again back to the Master Nursing classes. Good evening to every one of you. So please do press the like button and subscribe to the channel. And dear aspirants, we have the lots of the updates, so that is recently which we have had in the year of the 2025 and 2026, and the till date also continuously updates are keeps on coming. So I have not covered a recent updates which have came in the last 1 or 2 weeks, so that I am going to cover near exam all together. Okay, all together updates which we have, okay, which is started in the year of 2026 and the last part of the 2025. So all videos I will concise and I will give in a very beautiful manner. If you are watching that particular 10 to 15 minutes videos, so you will be getting all the updated knowledge. Okay, so the till the 2026 January, whatever the updates are there, that is already I have given in the app. Okay, so that one also I will concise and give to you all, so that is on the YouTube. Okay, don't have to worry. And for that one, you have to subscribe to the channel and hit the bell button. Whenever we will post the video, that will comes notification to you all. Okay, and please do join the WhatsApp channel as well. And in the WhatsApp channel, we are going to share the link of the classes which we are going to upload. Okay, I will concise 10 to 15 minutes class of the each updates, and I will post, so that you will get complete grip over the concept. Okay, let's begin the session without wasting a time, because already so there is and the more time happened now here. Okay, so let's begin with this powerful motivational line. Dear aspirants, always keep in your mind, this is the time to work hard, this is the time to dream big. So don't concise your dream to top 100, top 200, and the top 1, top top 1000 rank. Always keep your aim on the all India rank number 1. So if you are keeping your aim on the all India rank number 1, you will be in the top 100. If you are aiming for the top 100 ranks, you will be in the top 1000. If you are aiming for the top 1000, means you will be in the top 10,000. So your aim should be always all India rank number 01. Okay, so if you are getting the all India rank number 01, it should be your dream, then you will get the top 100 rank definitely. So always remember, you are studying and study perfectly, give your best shot. So after selection, so there is you guys have to go to those aims which is actually required to and which is actually near to your home. Okay, and joining the other aims, then again studying, then again writing exam, so there is no any sense in that one. Okay, giving the shot, give the best shot and get the best result. So that is one time, one shot, one result. That is our life-changing result. Okay, so always aim for the all India rank number 1. Okay, for that one you guys have to work hard and very hard. Okay, so that there should not be any compromise in your dream. So it should be a big dream, and have the attitude of the never give up. This is going to be a very important game changer here. Okay, yes. So let's begin the session here with this very important MCQ which we have here. Okay, so what is the primary? This was the MCQ which we have done. Okay, and yes, so here is the first question. What is the primary indication of the performing the tip surgery? Primary indication of the performing the tip surgery or the tips procedure. So what is your answer? Yes. primary indication for performing the TIPS procedure. What is the TIPS procedure, sir? The TIPS procedure, full form also they can ask. So that is transjugular, through the jugular vein we are entering. Where we are entering, sir? Intrahepatic portal shunt. Okay, portal system shunt. Sir, what does it mean, sir? The TIPS mean T stands here as the transjugular, I stands here as the intrahepatic, P stands here as the portal system, S stands here as the shunt. So this is the transjugular intrahepatic portal system shunt. So in this one, most importantly, you have to keep in your mind. So this is the a permanent management which we are going to perform for a patient who is having the portal hypertension, which is refractory to the basic treatments. Okay, so in the portal hypertension where there is the bleeding from the esophagus vein happens, so that is called as the esophageal varices. Okay, so esophageal varices means, so from the superficial veins of the esophagus bleeding will start. That is called as the esophageal varices. Sir, when that will start? When the pressure in the portal system, in the portal veins, when the pressure is increased, so that time the bleeding will be starts in the our most important esophageal veins. So that is called as the esophageal varices. So to control that bleeding, we are going to use the Sanger-Steken Blackmer tube, and the we have the Minnesota tube. Okay, so when we have used the Sanger-Steken Blackmer and the Minnesota tube, still there is the bleeding persists. So the definitive and the final management which we have is the, so that is the transjugular intrahepatic portal system shunt. Sir, what we are going to do in this one, sir? So we are going to remove the obstruction and we are going to establish the our venous system which was blocked. So that is we are going to re-establish. Okay, so the wherever the blockage is there in the venous system, that we are going to remove. So removed blockage we have removed means, so there is no pressure in the portal system. No pressure in the portal system means no pressure in the esophageal veins. No pressure in the esophageal veins means no bleeding from the esophageal veins. Okay, so this TIPS is the definitive management of the esophageal bleeding, and almost all people given the correct answer. That is the refractory portal hypertension with the variceal bleeding. So that is the esophageal variceal bleeding. So that is a correct answer for this question, and this is the primary indication of the TIPS surgery. Please do keep in your mind the TIPS surgery is important for the exams. Okay, so you can see here what we are going to do. So we are going to enter through the jugular vein. Okay, and we are going to come into the our inferior vena through the superior, like jugular, from the jugular vein to the heart, from the right heart to the inferior vena, from the inferior vena to the hepatic vein. Okay, so that is transjugular intrahepatic we came, and from here to the portal system, so to the portal vein. So here the obstruction is there, we are going to remove that obstruction. So we removed obstruction means there is no pressure in the other vein, superior mesenteric, inferior mesenteric. So there is no any pressure in this one. No any pressure in this one means, so there is no bleeding from the inferior and superior mesenteric vein, and from the esophageal vein, and from the pancreatic gastric vein. So these veins are not getting bleeding. So we can control those bleeding by the TIPS procedure. So that is the very important, you are going to remember here. Okay, yes sir. And here it comes to the next question. In the last class I asked the question about the during the monitoring of the central venous pressure, which position we are going to give. So that is the supine position with the head of the bed elevated 30 to 40 degree. Okay, so that is for the monitoring of the central venous pressure. So that is, I told the transducer should be at the level of the phlebostatic axis. Okay, in the last session we have done. But the now question is, while inserting the CVP, which position you are going to provide? So not while monitoring, while inserting the CVP. So I told the technique of insertion of the CVP, that is the Scheldinger techniques in the last class. Okay, so while inserting of that central venous pressure line, so which position we are going to provide to the patient? So the most important one option is telling that is the Trundlenburg position with the head turned to the opposite side. and option B, prone with the arms are extended. Option C, sitting upright with the head neutral, and option D is lateral decubitus with the head facing. So what is the correct answer? Yes, well done. Very nice. So that is the very perfect. Okay. Yes. So we are going to provide the trundle lumbar position with the head turned to the opposite side. This is very important. Right? Yes. So here we have the trundle lumbar position. That is, a head is down and foot is little bit up with a head is turned to the opposite side like this. Okay. Sir, why? Why? Because we want the proper access to the jugular vein. If the head is, we are inserting the right side, so head should be turned towards the left side. Okay, so we can easily access the jugular vein. So this is very important. And remember, if I am inserting the chest tube drainage, okay, so towards the left lung you consider. So this left hand should be behind the head. Okay, so this left hand should be behind the head. So because we can access the our left side, what we can say, like the intercostal space we can easily access. So which side you are inserting the like ICD tube, so that side hand should be behind the head. Okay, and one more very important, that is during the breast self-examination. So during the breast self-examination, we have to educate to the mother that, so that the right breast should be examined by the left hand and the left breast should be examined by the right hand. So while examining the left side breast, so the left hand should be behind the our head. So, and while examining the right breast, the right hand should be behind the head, and we are going to examine with the left hand. So this is the elevation of the hand and turning. These questions are important. First one I told, if you are inserting the CVP, right side face should be turned left side. Okay, and second situation or the scenario I told, while inserting the CVP line, while inserting the central venous pressure line, so we are going to educate to the like patient that if we are inserting left side, so the left hand should be behind the head. Okay, and so we are going to ask the patient to perform the Valsalva maneuver also. That is also very important point. Okay, so that is the take a deep breath and hold. So this will prevent the like movement of the chest, and that we can easily insert into the pleural space, and there is less chance of the injury because the chest is not moving, means it will not pierce away the our needle. So that is the most important. Okay, yes, education during the chest tube insertion, that is which side we are inserting, hand is behind, and the Valsalva maneuver. Similarly, the self-breast examination, the three situation and the three hand elevation situation. So the very important. Okay, yes, right breast should be examined by the left hand, left breast should be examined by the right hand, and most importantly, while examining the right breast, right hand should be behind the head. Okay, and while examining the left breast, left hand should be behind the head. So these are the very important clinical correlations you are going to keep in your mind. Okay, yes sir. So I hope it is very much clear. Then now my question is, sir, why trundle lumbar position? Sir, why trundle lumbar position? Yes, trundle lumbar position we are going to recommend here because if we are keeping the head a little bit down, means the venous flow is like this. So if we are keeping the head a little bit down, means so the venous flow will not go towards the heart, so vein will become younger, so the vein become big here. Okay, that is one reason. Another reason is if while inserting by accidentally any air is entered inside, means that will be getting trapped here only. Okay, so if air entered, so that already patient in the trundle lumbar position, give the left lateral trundle lumbar position. So this is the very important thing to be keep in your mind. Okay, very important, right? Yes sir. Next question is this one. This is your 5-star question. 5-star question. Please do keep in your mind. Very important. The burp maneuver during the rapid sequence intubation stands for what? It stands for actually. What is the meaning of the burp maneuver during the rapid sequence intubation? Option A, backward, upward, right pressure. Option B, bending under the rapid pressure. Option C, basic upper respiratory protocol, and option D, breathe under rapid. So what actually this burp stands here? Yes, the burp stands here is the, so this is a simple meaning of the burp is that is the backward, upward, right pressure. This is the burp maneuver. We are going to use this one during the rapid sequence intubation. Sir, what is the meaning of the rapid sequence intubation? So this I am going to take another class in detail. So where in the emergency, so we are going to use the insertion of the ET tube or the any advanced areas. So that is very fast, that is the rapid sequence intubation. So that one I am going to teach you separately. Okay, so don't have to worry about that one. Just now try to understand what is the burp maneuver. Burp maneuver is, that is the backward, upward, right pressure. Sir, where we are giving the pressure, sir? For what purpose we are giving the pressure, sir? What is the use of this one, sir? So this is the question which is running in your mind, I know. So for that one, we are going to study the golden points on the burp maneuver, because this is very important and a 5-star question. Okay, so can you start the golden point? Yes, sir. So what is the backward mean? Backward means we are going to hold the thyroid cartilage. Remember, not a cricoid cartilage. Here I am going to hold the thyroid cartilage and I will push the thyroid cartilage towards my spine. So this is the backward. This is the backward. Okay, so holding the thyroid cartilage and pushing towards the spine, that is the backward pressure I am giving over the thyroid cartilage. Okay, next. So again I am holding that same very important thyroid cartilage and pushing it up towards the head, which is pushing up towards the head. Okay, that is the upward, and a little bit right side I am pulling. Okay, so that is backward, upward and rightward. Okay, so backward, upward and right side. So this is, we are performing for what purpose, sir? Option A is to prevent the aspiration. Option B is to for the proper visualization of the our airway. So what is the main purpose of this one? Proper visualization or the preventing the aspiration? What is the main purpose? So preventing the aspiration is the 1000% wrong answer. The burp technique we are not performing for the prevention of the aspiration. We have the another maneuver to prevent the aspiration, that is the Sellick maneuver, we can say. During the rapid sequence intubation, we have the cricoid pressure or the Sellick maneuver. So there we are preventing the aspiration. For the burp technique, this burp technique mainly and mostly used for the improving the visualization of the vocal cord during the intubation. The very important golden point, quickly, perfectly I am going to revise. Listen carefully. Burp stands here is the backward, upward, rightward pressure. I told backward it means towards the spine I am pressing. Upward in the means towards the head I am pressing. Rightward in the sense towards the patient right side I am pressing. Getting? So that is what I am pressing. So that I am holding the thyroid cartilage in my hand, I am pressing. Okay, yes sir. So main purpose of this one is to improve the visualization of the vocal cord during the intubation. So that is the main purpose of the burp technique. Okay, so this is used during the difficult laryngoscopy and poor glottic wave is there. In that particular situation, we are going to use the burp technique. You can see here what we are doing. So we are holding the thyroid cartilage and pushing it backward, pushing it upwards towards the head and pushing it right side. Okay, yes, pushing it backward, upward and the right side, that is the backward, upward, right side pressure, that is the burp technique. That's the burp technique. The main purpose is to visualization of the our vocal cord when the laryngoscope is failing and the poor glottic wave is there. So that time, very important, very important. Next question comes here in front of you. So give the best shot to this particular question. Yes. Which of the following is true about the Sellick maneuver? Which of the following is true about the Sellick maneuver? So what is the correct answer in the given 4 option which we have here? Okay, so that is Option A is telling that which improves the lifting of the chin upward. Sorry, it involves the lifting of the chin upward. No, Sellick maneuver will not lift any chin and head. Nothing is there. So I am eliminating the option A. Then comes to the option B. Okay. Then comes to the option B. It is used to create a clear view of the vocal cord. Sir, just now only we have discussed that is the clear view of the vocal cord we are getting by the Burp technique, not by the Sellick maneuver. Okay, so I'm eliminating the option B also. Right? Yes, sir. Then option C, it applies the pressure to the cricoid cartilage to compress the esophagus is the perfect and the very perfect and the very, very perfect answer. So that is Sellick in the sense hold the cricoid cartilage here. Beta in the Burp we are holding the thyroid cartilage. In the Sellick we are manipulating the cricoid cartilage. In the Burp technique we were manipulating the thyroid cartilage. Nothing is there. So this most protruded area, this is the thyroid cartilage, we also call as the Adam's apple, and just beneath of this one we have the cricoid cartilage. Okay, so this cricoid cartilage we are pressing here during the rapid sequence intubation because there is a chance of the regurgitation and aspiration is there. So the food will comes from the stomach into the esophagus, esophagus into the lungs. If I am pressing the cricoid cartilage, that will create the pressure on the esophagus, so that esophagus, the content will not come out of the esophagus. If it is not coming out of the esophagus to the throat, means there is no aspiration. Yes, this got to the perfect answer, and almost all of you have given the correct answer. It applies the pressure on the cricoid cartilage and compresses the esophagus. So this is the perfect and a very perfect answer. So I'm very proud of you all. Almost 90% and more than 90% of you all given the correct answer. Right? Yes. Option D is it is not recommended during the it is perfectly recommended during the rapid sequence intubation. Okay. Yes. So here we have the golden points on the Sellick maneuver. Sellick maneuver we also called as the cricoid pressure. We also called as the cricoid pressure. And the next we have, it is Sellick in the sense it is not having any full form, but a Burp in the sense we have the full form. That's the backward, upward, rightward pressure. So that's the Burp in the sense which is having the full form. Here the Sellick is not having any full form. Sellick is the name of the person who discovered or who described this maneuver. That is the brain Arthur Sellick. So the name of this brain Arthur Sellick, we have taken only Sellick and we have kept the name as a Sellick maneuver. Okay, yes sir. And so here what we are doing, we are making the pressure over the cricoid cartilage so that will compress us the, so that is cricoid cartilage is just below the thyroid cartilage. Okay, so that is compressing our esophagus. Okay, which prevents the aspiration. So purpose is to prevent the aspiration of the gastric content, right? So mechanism how it is working, compressing the esophagus against the vertebral body. So if you are compressing the esophagus, so there is no gastric content will come back. Okay, so this is used during the rapid sequence intubation. So that is important and very important. Yes, so some very important updates which we have, that is on the pancreatitis fluid management, that is recently got the update that I am going to discuss in the future classes. Okay, so what we were using, we were studying previously, that is the keep NPO for the prolong. So now NPO prolong is not recommended. Okay, so early feeding and all, and the fluid resuscitation. So there in the fluid resuscitation also fluid of choice have been changed. And the most importantly, yes, we will discuss all the things. Don't have to worry. We will get the a separate and the very perfect class on that one. Okay. So all the updates, separate classes I am going to upload. So just you subscribe to the channel and you will get the notification. Learn it before the exam, practice it before the exam, and win the exam. That's it. Okay. Yes. What is the purpose of this Sellick maneuver during the intubation? So yes, What is the purpose of the Sellick maneuver? Just we have discussed this one. It is not to increase the airway patency. It is not to relax the vocal cord. It is not to enhance the oxygenation. This is just to prevent the aspiration by applying the required pressure. Just now only we discussed, and this is the question you may get directly in your exam. Okay, so you may get this one directly in your exam. So this is the 5-star question. Remember. Okay, yes. Next we have this one. So where we have left in the last class, I have asked this question to you all. Okay, and we have made the some half calculation. Okay, yes, some of you have come to the conclusion of the answers also, and many of you have posted your answer in the last class. So that is very simple. The question on the cerebral perfusion pressure calculation. Yes, the patient has the systolic blood pressure of the 120 mmHg and diastolic BP of the 80 mmHg, and intracranial pressure we have the 10 mmHg. What is the cerebral perfusion pressure is the question. Okay, yes. So how we are going to check the cerebral perfusion pressure? Yes, so to check the cerebral perfusion pressure, we require the mean arterial pressure and intracranial pressure. Sir, intracranial pressure is already given in the question. So we are going to first calculate the mean arterial pressure. So in this mean arterial pressure, we are going to deduct the intracranial pressure. That will give the cerebral perfusion pressure, right? Yes, sir. So how we are going to calculate the map? So this is the simple formula we have. That is the 1 into SBP plus 2 into DBP divided by 3. Okay, yes. So SBP which is given in the question is that is 120 mmHg, DBP is 80 mmHg. Same thing I will fill here. So that is 1 into SBP. So that is 120 into 1 is the 120 again, and 2 into DBP, that is the 2 into 80 is the 160. So that is the 120 plus 160 is the 280. So remaining 3 I will keep here same, and I will divide the 280 divided by 3. So the answer will comes is the 93.3, right? So the 93.3 will be the answer here. So the question is, they have not asked you how much is the mean arterial pressure. In the option you will be get the 93, also you will get the option. So almost all you people, you will finish the calculation till here, and you guys going to choose the correct answer as the 93. But so here we don't have the option called 93, right? Yes. So the question is also not asking you about the mean arterial pressure. Just we have just now we have calculated the mean arterial pressure. Now we are going to calculate the cerebral perfusion pressure. That is the mean arterial pressure minus intracranial pressure. So how much is the mean arterial pressure we got here? That is the 93 is the map we got here. Okay, so same 93 I am going to keep here, and the intracranial pressure which is already given in the question. So you can see the in the question. So we have the intracranial pressure which is already given, right? Yes, sir. So that 10 mmHg intracranial pressure I am going to deduct from the 93. So the 83 will be the answer, and so this is the perfect answer. So which we have here. Okay, yes. So almost all people have done this question correctly and perfectly in the last class. Okay. So before previously also I have discussed this concept with you all. So that is I'm very proud of you all. So because you all are retaining the concepts, you are applying your knowledge in the questions, and you are getting the good and the perfect answer in the exam. So that is what as a teacher I want. This is actually what I want. So I am teaching, and you are understanding, and you are giving the best shot when the question comes in front of you. So this is actually a success of the teacher. This is actually a success of the hard working student, right? Yes, sir. So yes, let's begin the next question here. Here it comes to the next question. The question is simple but very important. Which of the following is the most common cause of the fever on the post-operative day 1? On the post-operative day 1, what is the most common cause of the fever is the question. Option A, UTI we have. Option B, we have the wound infection, and option C, we have the pulmonary atelectasis. Then option D, we have the deep vein thrombosis. What is the correct answer for this one? Yes. So that is the perfect answer. The pulmonary atelectasis is the most common cause of the post-operative day 1 fever. So this is the perfect answer. Okay, sir, what is the atelectasis? What is the mean of the atelectasis, sir? Yes. What is the atelectasis? Atelectasis is the collapse of the alveolus. Sir, why here collapse of the alveolus happening, sir, due to the post-operative in the post-operative period, sir? The two regions. One is, this is the our thoracic cavity we have, and here it comes to the our abdominal cavity. Okay, this is divided by the a muscle called as the diaphragm. This is divided by the muscle called as the diaphragm. Okay, so question will come, which muscle divided the thoracic cavity and abdominal cavity? That is by the diaphragm, the main muscle of the respiration. This is divided the thoracic and the abdominal cavity. Now you consider that the incision is made here, like we have done the some splenectomy, we have done the some what we can say, this side splenectomy you consider, and this side you consider the pancreatitis, the pancreatectomy, whatever the some surgeries we have done near the abdomen. Okay, so when the patient is taking the breathing, so that time this diaphragm can move down and up, down and up, so it is moving inside, means it is causing the pain here. So the patient will unable to take the deep breath, especially on the abdominal incisions. So that time what happens? So the not taking the deep breath means alveoli will start to collapse. So the alveoli are start to collapsing, means we call that is the atelectasis. One reason. And the second reason is, so here we have the chest, okay, and in the chest we have the like intercostal muscles. So these all intercostal muscles and the diaphragm and the respiratory muscles which we have, so that will get weak, and that will be getting the having the insufficient action due to the effect of the anesthesia. In the general anesthesia, all the respiratory muscles will got paralysis. Okay, so because of this respiratory muscle paralysis, so the strength of the muscle is not coming back on time, so that is also going to cause the atelectasis. The alveoli are getting collapse, means this will cause the post-operative day 1 fever. So this is very important to be keep in your mind. Okay, so this is very important and very important, right? Yes, sir. So now I am going to throw some questions, so please try to answer to the questions. Okay, yes, so that is just a simple terminologies of the respiratory disorders, right? So patient is having the obstruction in airway, so that is chronically, okay, and which is irreversible. And when we will check the chest circumference of the that particular patient, so that where we are getting the a barrel shaped chest. So what may be your diagnosis? Chronic irreversible airway obstruction plus barrel shaped chest we have. Yes, that is the, we can say, COPD, and we also say emphysema. Emphysema is part of the COPD, right? Right? Yes, sir. So what is the main problem in the emphysema? What is the main problem in the emphysema? In the emphysema, air will go into the respiratory tract, in the trachea, and it will go into the terminal bronchi, okay, and it will causes the trapping of the air due to the loss of the elasticity of the respiratory bronchioles. Okay, so air will get trapped into the our lungs only. So air is getting trapped into the lungs, means so the lungs anterior posterior diameter will increases, and where we will be getting the barrel shaped chest. Okay, so that air, whenever we are trying to exhale it out, so the lip will be exposed to the more oxygen, so more air, so that the pink puffers we are going to see in the emphysema. Okay, so pink puffers in the emphysema, and where we are going to see the blue bladders. Yes, blue bladders will be seen in the chronic bronchitis. Okay, so the chronic bronchitis, where we are going to see the blue puffers, and the in the emphysema the pink puffers. Okay, yes, so that is very important. All right, so now I will come to the conditions of the pleural cavity. So in the pleural cavity, blood is accumulated. What we can say? So accumulation of the blood in the pleural cavity. Yes, that is the hemothorax. Accumulation of the accumulation of the fluid in the, yes, accumulation of the fluid in the our pleural cavity. What we can say that one? So that is the hydrothorax. Okay, so accumulation of the like lymphatic fluid in the our pleural space. What we can call that one? Accumulation of the lymphatic fluid in the pleural cavity. What we can call that one? Yes, that is the chylothorax. Sir, what is the chylothorax, sir? In the chylothorax, the lymphatic fluid is going to accumulate in the pleural space. Okay, yes. So I hope these terminologies are very much clear to every one of you. Right, yes. So I am going to revise all the post-operative day and the likely cause of the fevers. So please do keep in your mind. So post-operative day 1, the most common cause of our fever is the atelectasis, that is the collapse of the alveoli. Okay, and day 1 to day 2, the cause of the fever is the pneumonia. Okay, so that is most importantly the infection and inflammation of the lung parenchyma or the lung tissue. So that is the pneumonia is the cause of the post-operative day 1 and day 2. Okay, so day 3 and day 3 to 5. So that is the deep vein thrombosis or the surgical site infection is the cause for the day 3 to 5 cause of the fevers. Okay, and most importantly the burst abdomen, when it will happens, that will be 4 to 6 day. Okay, after the surgery, day 4 to day 6 of the after the surgery, there is a chance of the burst abdomen. Okay, so the next we have the last, that is the day 5 to day 7, that is the intra-abdominal abscess is the cause. Okay, so that is the most important you are going to keep in your mind. That is post-operative day and the likely cause of the fever here. So this is important for the exam. And now try to identify this image. This is the image-based question. This is the image-based question. Yes, try to identify this image. Try to identify this image. This is the, what we can say, a sudden expulsion of the entire visceral organ of the abdomen outside of the our abdominal cavity. So that is by piercing the surgical site. So this is what we call the burst abdomen. We call this one as the burst abdomen. So that is, we can say all the abdominal viscera is expelled out. Okay, and so this is called as the burst abdomen. In this burst abdomen, we are going to perform one very important and simple surgery. So this is called as the, this is also image based questions you may get. So that is bag-to-bag surgery. So what is this one? So this is the bag-to-bag surgery. Sir, what it means, sir? So here all the expelled abdominal organ we are repositioning and which we are suturing by the most important sterile plastic urine bag. Okay, so the sterile urine bag, the plastic urine bag which we are taking and which we are resuturing with the edge of this burst abdomen. Okay, so that we are keeping the all the abdominal intra-abdominal organs safe and like sterile and without infection, so that we are keeping here. So this is called as the bag-to-bag surgery. Just the bursted abdomen we are suturing with the help of the our sterile urine bag. So this is very important to be keep in our mind. Okay, so from here we may expect the question. Then comes this one. What is this one? The image based question. Again the image based question. What is this one? Yes, the surgical complications. So what happened here? You can see the sutures are there. The sutures are there. These sutures are got separated here. So these sutures are got separated here. So what is this? Yes, this is an dehiscence or the evisceration. So this is just a separate in the suture line is there. So suture line is opened, just the organ is not came out. The suture line is opened, organ is not came out. So this is the most importantly the dehiscence. Okay, so this is dehiscence, very important, right? So next image we have here, you can see this one. So you can see here the suture line are just got separated, and viscera, the internal organ, is not come out. So this is the dehiscence, what we can say. Okay, and here you can see the internal organ which came out. So this is called as the evisceration. The difference between these two are the very important. Okay, so dehiscence and evisceration, whenever you will find in the post-operative ward, immediately you have to inform to the physician. And if you found the dehiscence and evisceration in uncovered wounds, so first priority nursing intervention is to cover these wounds with a gauze piece. Okay, sterile gauze piece we are going to keep over the wound, and we are going to call the consultant surgeon. So this particular surgeon will come and he will take the patient next to the minor OT or to the major OT, and he will do the repair of that one. Okay, so first priority nursing intervention is to don't allow this wound to get exposed to the bare environment. Just try to cover this wound with the sterile gauze pieces. This is important and very important for the exam, right? Yes, sir. So remember, the image based questions may ask, or they may ask the definition. Evisceration means the suture is opened and from the surgical side the organ is came out. So that is the visceration. So viscera is come out. That is the viscera in the sense organ. Okay, yes. So viscera in the sense organ. So organ come out is the evisceration, and just separated, just one part become the two. That is the die. So that is the dehiscence, is the just separation into the two separate is there. So that is the dehiscence, is the separation, and from the separated side the organ coming out is the evisceration. Both are important for the exam. Please do keep in our mind. Okay, and here it comes to the next question. Yes, a patient's ABZ, their aspirants, remember ABZ, ECG, surgical complications, tuberculosis, HIV, and Rogam injection, anti-tubercular drugs, everything which is multiple times striked in the exam. Okay, so there is no any nursing exam in view of me, so without ABG question. Definitely ABG question will come. That may comes from the sample collection technique, sample transport technique, and the Allen's test, modified Allen's test. So in that one the question have been arised multiple time. ABG interpretation, the treatment of the conditions of the abnormal acid base imbalance. So the multiple type of the questions have been come. So I request every one of you who all are not watched my ABG session, there is on the 2-hour dedicated separate session on the arterial blood gas. So from where definitely you are going to get the 3 to 4 questions in your including prelims and mains. Kindly watch that one. Okay, so you search the ABG class in the Master Nursing Classes channel, the completely 2-hour dedicated session where all the possible questions, concept and the theory very perfectly explained. So you watch that one, definitely it will be helpful for you. Okay, so now try to focus on this high yield question and try to get the best answer. The patient is showing a pH of the 7.30. Now you tell me, every one of you, leave the interpretation. Now tell me the answer to my question. What is the normal blood pH? What is the normal blood pH? Try to respond to this question. Normal blood pH. Very nice. So that is 7.35 to 7.45. So this is the normal blood pH. Remember, very important. So if the pH is less than the 7.35, I will call that one as the acidic pH, where the H plus ion is more H plus ion. So the pH will be less. Okay, so if the H plus ions are more, pH will be going to less, right? Yes, sir. So here the pH is less than 3.5, that is the acidic, and the pH is more than 7.45, so that is the alkaline. Okay, less than 7.35 is the acidic, more than 7.45 is the alkaline. Normal blood pH is the 7.35 to 45. So now you tell me, what is the normal PaCO2? What is the normal partial pressure of the carbon dioxide? What is the normal partial pressure of the carbon dioxide? Yes, so you do one simple, very important and very simple thing, that is you bring this 35 here and you bring 45 here. Okay, so that is 35 to 45 kilogram, right? right? So 35 to 45 kilogram, right? No. So this is partial pressure of the carbon dioxide. We are talking about the pressure. So there is the 35 to 45 mm of Hg. So these units are very important. Please to keep in our mind. Okay. So normal blood pH is 7.35 to 45, and the PaCO2 is the 35 to 45 mm of Hg. So now you tell me what is the HCO3? This is bicarbonate. What is the normal value of the HCO3 or the bicarbonate? What? Do answer to my question. Normal value of the bicarbonate. That is, as per your NCLEX book, 21 to 28 milliequivalent per liter. So this is the normal value of the our bicarbonates. Important. Please do keep in our mind. Okay, yes, sir. So the next we have is that is the partial pressure of the oxygen. So how much is the partial pressure of the oxygen? I am not asking about the saturation of the oxygen. I am asking about the partial pressure of the oxygen in the arterial blood. So that is the 80 to 91 mm of Hg. Sometimes it will go up to 100 mm of Hg, but so this is the in range and average answer, 80 to 91 mm of Hg. Okay, important. So now you tell me, so that patient is having the hyperventilation, taking the very deep breath and exhaling, taking very deep breath and exhaling, What will get eliminated from the body? Yes. So when we are taking the deep breath and exhaling, that time the carbon dioxide is going to eliminate from the body. So in the deep breathing and in the hyperventilation, this PaCO2 is going to decrease. Okay. So now you consider patient is having the COPD. Patient is having some lung diseases. So that time there is no elimination of the carbon dioxide. So that time what happens? The PaCO2 is going to increase. Okay. Yes. So this PaCO2 is increased and the pH is decreased. So we call that one as the respiratory acidosis. Okay, what we call that one is the respiratory acidosis. Okay, if in case I told the hyperventilation, patient is excessively taking the deep breath and he is eliminating the more carbon dioxide. So that time PaCO2 is going to decrease. And pH is going to increase. So pH is going to increase more than the 7.45. PaCO2 decreased, pH is increased. So this is called as the respiratory alkalosis. Okay, so what we can call respiratory alkalosis. In simple, in perfect, I am teaching you all. So try to understand the concepts. Okay, yes. So next we have the bicarbonates. Okay, so the next we have is the bicarbonate. If in case the bicarbonate is increased means the pH also will increases, because this is the alkalizing agent. So this is the alkalizing agent. If the bicarbonate is increasing means the pH also going to increase. Increased bicarbonate, increased pH, which indicates the metabolic alkalosis. If in case bicarbonate is decreased, pH also decreased, which indicates the metabolic acidosis. So now try to give the answer based on this knowledge which I have told you. So you apply that one here in this particular question. The patient's ABG shows that a pH is 7.30. So now tell me, acidic or alkaline? Yes, this is less than our 7.35. So I told less than this one is the acidic. Okay, so the pH is less than 7.30 here. 7.35 kinta kadime ide. So it is less than the 7.35. So that is, we can say this one is in the acidic. Okay, so this is acidic. Now this is respiratory or the metabolic. How we are going to check? So check the PaCO2. So here PaCO2 is going to PaCO2 is already increased. So that is something problem is in the respiration. So there is maybe any respiratory conditions where the carbon dioxide is retained inside the body. So where the carbon dioxide is retained inside the body, so it is the problem, that is the respiratory problem. This is the respiratory problem. Okay, so you can see here the bicarbonate is absolutely normal. So that is the 21 to 28 milliequivalent per liter I told. So here it is having the 24. So this is bicarbonate. Okay, so normal means there is not in the metabolic problem. This is purely a respiratory problem. This is the respiratory acidosis, where it is the answer. The respiratory acidosis is the answer for this question, and very important. Now you tell me, this is the compensated or uncompensated? Yes, this is the compensated or uncompensated or partially compensated. What is your answer? This is compensated, uncompensated, or partially compensated? Yes. So listen carefully. Whenever there is a respiratory problem, that time the bicarbonate we are going to check the compensation. Okay, and pH we are going to check the compensation. The bicarbonate is increased and the pH comes to the normal, we call that means completely compensated, or the compensated respiratory acidosis. Here there is no increase in the bicarbonate, there is no pH coming towards the normal, so this is completely uncompensated respiratory acidosis. Okay, so understand now, sir, why bicarbonate will increase, sir? Here, so here we are having the acidosis, right? So whenever the acidosis is there, so that time our kidney will reabsorb all the bicarbonate and it will try to compensate the acid base imbalance which happened. So in order to compensate, so the kidney will reabsorb the bicarbonate and the bicarbonate will increasing. So that time I told the bicarbonate is the alkalizing agents. Okay, so the bicarbonate is increasing means the acidosis will be reducing. Okay, so acidosis will comes towards the normal. Okay, so here it is not increasing, so it means it is completely uncompensated. Okay, for example, now you say, so the same situation, the bicarbonate, the HCO3 in this particular question is 35 milliequivalent per liter. So now you will see this is, and along with this one I am going to write the pH. Okay, that is the 7.32. So pH came to the normal? No, sir, it is not come to the normal. But bicarbonate is increased? Yes, sir. So pH not come to the normal, but bicarbonate increased. So it means something trying to compensate is there. So we can say this is the partially compensated. So we can say this one is the partially compensated. So here the bicarbonate also increased and pH also comes to the normal. pH also comes to the normal. So that indicates it is fully compensated respiratory acidosis. Okay, so it is respiratory acidosis which is fully compensated. When we will say, to say it is fully compensated, the pH should be comes to the normal. Okay, so if pH is not normal, I will not say this is fully compensated. Okay, yes. So the very important, the basic diagnosis we have done, and we have seen towards the our bicarbonate, there is no change in the bicarbonate, it is uncompensated. Bicarbonate little bit increased, but pH remains acidic only, this is partially uncompensated. And the bicarbonate increased and pH comes to the normal, that is the completely compensated. So these are the three very important situations and the very important conditions which we will get. And watch the ABC session completely to our session. You will be having the zero doubt. You will be having the zero doubt on the ABC, and whether they will ask the like whatever kind of the question they are asking, you are going to throw the answer like a pro and pro max. Okay, yes. So let's go for the next very important question here. So try to answer this one. There is a 25-year-old presents with a 2 days history of the profuse diarrhea. So there is in the 2 days history of the profuse diarrhea. So yesterday we have completed this concept, I think so. So I want everyone's complete and the best answer. Yes. So there is in the 2 days history of the profuse diarrhea is there, and his ABC is revealing that pH is 7.30. Yes, the pH is a lower side, which means it is acidosis or alkalosis. This is purely again the acidosis. What I told, less than 7.35 is the acidosis, more than the 7.45 is the alkalosis. Okay, here it is having the less than 7.35. okay, it is less than 7.35, that is the less than, so what we have is the less than 7.35, that is the, we have the value 7.30, so which is the purely an acidosis. Okay, so first I decided this one is the acidosis, right? Yes. So now I will see towards the bicarbonate. So the bicarbonate, what I told normally which we have, so that is 21 to 28 milliequivalent per liter is the normal I told. So here the bicarbonate also decreased. So bicarbonate also decreased means this is the metabolic problem. This is the metabolic problem. Okay, so you see towards the PaCO2. PaCO2 is only 30 mmHg. So what happens to the PaCO2? PaCO2 is also decreasing. Okay, yes sir. So PaCO2 is decreased because of the compensation. Because here in the metabolic acidosis, you know, whenever there is in the metabolic acidosis will happen, that time respiratory rate and depth both will increase. What we call that one is the Kussmaul's breathing. So what is the Kussmaul's breathing? The increase in the rate of the respiration, increase in the depth of the respiration in order to eliminate the more carbon dioxide, in order to compensate with the acidosis, right? Yes sir. So here the metabolic acidosis is there. So body started compensating and it is started eliminating the more carbon dioxide. So because of the acidosis, right? Yes sir. So now the PaCO2 is decreased due to the compensation. But you see PaCO2 is decreased here. PaCO2 is decreased here, but pH not comes to the normal. So can we say this is fully compensated? No sir. So but can we say this is the partially compensated? Yes sir. So this is and the partially compensated. Okay, so this is an partially compensated metabolic acidosis is the diagnosis. Okay, yes sir. So the question what actually asking, what is the most likely cause of this particular acid base imbalance is the question. So for this acid base imbalance, what is the most likely cause? So that is a profuse diarrhea. So I told we have a very important GS system like this. Yes, so we have a very important GS system like this. So that is esophagus. Okay, yes sir, and the stomach. Yes sir, and the intestine. Yes sir. So here we have stomach. Inside the stomach, HCl is there. So during the intermittent gastric suctioning or during the vomiting, HCl will go out of the body. So hydrochloric acid is decreasing from the body. So in the body, acid is decreasing. Acid is decreasing means what happens? The H plus ions, acid is decreasing, it means the H plus ions are decreasing. Okay, yes. So the H plus ion is decreasing means what happens to pH? pH will increasing. So here pH is increasing, which means what we can say, call this one, we call this one as the metabolic alkalosis will happens. Okay, so because of the loss of the acid, so there is in the alkalosis will happens. And similarly I told here our lower GI system, so that is rich in the alkaline mucosa and bicarbonate. Okay, so in the profuse diarrhea, so there is in the loss of the this particular alkaline agents and like alkaline mucosa and the bicarbonate which is going out of the our intestine. So we are getting lots of the bicarbonate. Okay, so due to the loss of the alkalizing mucosa and bicarbonate, so bicarbonate is decreased means the pH will be decreases, because the bicarbonate is responsible for keeping the pH under control and it will suppress the pH in the normal. Bicarbonate decrease means pH also will decreases. Remember, very important. So here bicarbonate decrease means pH will be decreasing. So pH decrease means we call that one as the acidosis. Okay, so what we can call this one as the acidosis. So which acidosis, sir? That is the metabolic acidosis. Okay, yes. So the cause of this metabolic acidosis is the question here. So here the cause of the metabolic acidosis is not a lactic acidosis. So this is the wrong option. Lactic acidosis happens when there is an improper perfusion towards the peripheral vital tissue. So that time the lactic acid will releases, especially in the shock hypoperfusion situation. Okay, in that situation the lactic acidosis will happen. Okay, yes sir. So this is not a reason here, because here the reason is the diarrhea. Okay, so next comes to the diabetic ketoacidosis. Diabetic ketoacidosis happens due to the excessive uncontrolled breakdown of the fat. So when the fat is breaking, that time the ketone bodies are increasing, that is causing the diabetic ketoacidosis. Okay, so in the diabetic ketoacidosis, again similar metabolic acidosis form. So in order to compensate the metabolic acidosis, so there is an increased rate and depth of the breathing, the small breathing we are seeing, so the PSCO2 is going to reduce. Okay, yes. So next we have is the cause of this one is the bicarbonate loss from the GI tract due to the diarrhea. So this is going to be a correct answer, and please do remember this one. This is important for the exams. Okay, yes sir. And here it comes to the next question. A 22-year-old woman is there, so who is with the eating disorder, and she persistently having the weakness, and she admits to ward with a very frequent self-induced vomiting. ABG is showing that the pH is 7.50, which is more than the 7.45, so which clearly indicating this is the case of alkalosis. Okay, yes sir. And the bicarbonate is also increased, so that is more than 28, that is the 34 is there. So this is a metabolic problem. Okay, so the diagnosis here is the metabolic alkalosis. Okay, and PaCO2 is little bit increased, so that is in order to compensate. So the pH is not normal, but the PaCO2 is little bit increased, so we can say partially compensated. Okay, so this is, we can say, partially compensated metabolic alkalosis, right? Yes sir. So the answer only it came directly. Okay, so that is, which one is the option? Option we have metabolic acidosis. No, this is alkalosis. Then option B, respiratory alkalosis. No, it is not a respiratory problem. Okay. Option C we have, this is the metabolic alkalosis. Yes, this is purely a metabolic alkalosis. Okay. Yes. So then the option D is the respiratory acidosis. So that is not a correct option. So that is I am eliminating. Okay. So I hope it is very much clear to every one of you, right? Yes, sir. So now you are trying to tell me the interpretation, so which I am going to show you here. So you are going to tell me the interpretation, which I am giving the value to you all. Okay. So whenever you will see a patient with a COPD, so the PaCO2 is 50 mm of Hg, and pH is 7.28, and PaO2 is 60 mm of Hg. So what is your interpretation? And bicarbonate HCO3 is 30 milliequivalent per liter. So what is your answer? What is your answer? First of all, so this is a acidosis or alkalosis. This is purely acidosis. Yes sir. Yes. So next we have, that is problem with the respiratory or metabolic, we will check. So we will go for the PaCO2, where the more carbon dioxide is there, so that is the respiratory problem is there. Okay, so bicarbonate is increased here. When the bicarbonate increased, acidosis will not happen. Getting the point? So means it is not in the metabolic problem. This is the respiratory problem. So now bicarbonate is increased here. So it is increased in order to compensate with this one. Okay, but the pH is not normal. So it is fully compensated or partially compensated. So we can say this one is the partially compensated. Getting the point? Yes, sir. This is purely respiratory acidosis, which is partially compensated because the bicarbonate is elevated to compensate, but pH is not still came to the normal. When the bicarbonate is increasing and pH comes to the normal, so we can that time we will say this is the respiratory acidosis, which is fully compensated if the pH comes to the normal. Okay, so here it is not comes to the normal. So, but the try is happening, the compensation is happening. So that is the partially compensated respiratory acidosis is the answer. Okay, yes, sir. So now the second question which I am going to give you all here is, so let me make it a little bit small. Okay, yes. So the next interpretation which I am giving you all. So I will make you completely perfect now today here. Okay, yes. So that is, we have the PaCO2 that is 30 mmHg and the pH is 7.50 and the HCO3 is 20 milliequivalent per liter. So can I write this one as in the 16 milliequivalent per liter. So now tell me the interpretation. And the PaO2 is normal. So that is we can say 90 mmHg is there. Okay, no problem with the PaO2. So now tell me the interpretation of this one. The first problem. So what happens to the PaCO2 carbon dioxide? Carbon dioxide is reduced. So it is reduced means it is not in the acidosis. It is the alkalosis only, right? So the pH is what happened? The pH is increased. So pH increased means purely we can say that is the alkalosis, right? So the PaCO2 what happened? What happens to the PaCO2? PaCO2 is the 30 mmHg means which is decreased. So that is the problem is there here in the respiratory. Okay, respiratory problem. So now this case is the respiratory alkalosis. Now you tell me here the bicarbonate is reduced. Bicarbonate is reduced because it want to compensate the alkalosis and it brings the alkalosis back into the normal. So it is tried to compensate, but the pH is not normal. So that is what we can say partially compensated. Partially compensated respiratory alkalosis. Okay, so these are the questions which may strikes like this in your exam. So please do keep in your mind. Okay, and if the pH is coming to normal, then only you say that is the fully compensated. Otherwise, you don't say that is the fully compensated. Okay, yes, sir. And there is unchanged bicarbonate and unchanged thing is there. So that is we can say completely uncompensated. Okay, so now try to give the answer to this one. Yes. A 40-year-old patient is there with a mechanical ventilator. He is noted to have the ABG, that is pH is 7.55 and the PaCO2 is 25 mmHg and the bicarbonate is 24 milliequivalent per liter. What change to ventilator setting is most important here? So patient is on the mechanical ventilator. So whenever we will see the ABG value of that one, so there is on the increased pH is happened, which means alkalosis happened, and the partial pressure of carbon dioxide comes to the 25 mmHg means more carbon dioxide eliminated, which means more carbon dioxide eliminated, which means the hyperventilation happened. Okay, getting the point? Yes, sir. So due to the mechanical ventilator setting, there is in the hyperventilation is happening. What change to the ventilator setting is going to be a most appropriate here? Option A, increase the tidal value. Already there is in the hyperventilation happened, more oxygen went inside and the more carbon dioxide eliminated outside. You are again increasing the tidal value. That is again going to increase the oxygen and reducing the carbon dioxide. Again, the patient is going into the respiratory alkalosis. That we don't want. Okay, so the tidal value means what, sir? What is the tidal value? The amount of the air which we will intake and exhale in a one very important respiration, that is the tidal volume, so which is around the 500 ml. Okay, so the tidal volume will be the 500 ml, so that we are inhaling, exhaling normally in that one. How much amount of the air we are inhaling, exhaling, that's the tidal value. Next we have option C, that is the increase in the FiO2. So what is increase in FiO2? So what is the meaning of the FiO2? FiO2 is the fraction of inspired oxygen, which means I am taking the bulk of the air inside my lungs. In that one, how much oxygen I am inhaling. So naturally, in my environment and in your environmental air, so we have the 21% of the oxygen in the oxygen which we are inhaling. So that is the fraction of the inspired oxygen. So this is 21% normally we have. Okay, so if you are increasing the FiO2, that is the concentration of the oxygen, if you are increasing, again the more oxygen will go inside and it will suppresses the carbon dioxide again. So that is going to be a, again most importantly, that is going to be a cause the respiratory alkalosis. Already a patient in the respiratory alkalosis, so this one we are not going to perform. So if you are decreasing the PEEP, then again it is not going to be helpful. So what we are going to decrease is, so we are going to decrease the respiratory rate. So respiratory rate we decrease means there is insufficient oxygen will go. Okay, so the carbon dioxide will retain inside. So the carbon dioxide will improve and it will comes to the normal, that is 35 to 45 range it will come, and pH it was increased, so that will comes to the normal, it will comes to the 7.35 to 45. Okay, so the correct answer for this one is the option B, decrease the our respiratory rate. So nowadays you may get or you may not get the direct question from the ABG, but the applied question from the ABG you will definitely get. Okay, sir, which treatment you are going to give this particular patient? So first diagnose this one. What I told, this one is the case of the respiratory alkalosis. Sir, how you told, sir? So the pH is more than 7.45. So I told this is in the alkalosis. And here due to the hyperventilation, so the respiratory reason is there. So there is the respiratory alkalosis. What is the treatment for the respiratory alkalosis, sir? This is the asked question, and in the yesterday's class also I asked for this question. How you are going to treat the patient with the respiratory alkalosis? Yes, so you are going to treat the patient with the respiratory alkalosis by the paper bag rebreathing. Okay, so we will ask the patient to exhale in the paper bag and re-inhale that particular air what you exhaled, because in the exhaled air more carbon dioxide is there. So patient is exhaling, so he is re-inhaling, that one means the carbon dioxide will go inside and the carbon dioxide will retain. So the treatment for this one will be the paper bag rebreathing will be the very important. We are going to educate the patient. Okay, yes. So what is the drug of choice for the metabolic acidosis? The drug of choice for metabolic acidosis? Yes. What is your answer? Drug of choice for the metabolic acidosis? I want answer from every one of you. What is the drug of choice for the metabolic acidosis? In even A1 and A2 plan, in the pharmacology subject-wise test, we have uploaded most important teratogenic drugs and its teratogenic effect, most important drugs and its specific side effect, and most important drug and where which will be used as the drug of choice, most important drug and its adverse effect, and many tests to be uploaded in the pharmacology. So please do attend the every test of the pharmacology. We have given very few and concise and the precise syllabus we have given, so definitely questions will strike from there without missing. Please do upload update and please do study that one. Okay, that is going to helpful and going to cover the maximum questions which is from your pharmacology. Okay, so drug of choice for the metabolic acidosis, very perfect. So that's the injection sodium bicarbonate. Okay, so that is the sodium bicarbonate, because bicarbonate is going to reduce the acidosis. Okay, so this is the alkalizing agent. So the how it will going to reduce everything I explained in the ABC class. You are going to study that one also. That is going to helpful for you all. Okay, yes. So here it comes to the next question. Very important. The lead which we are going to place at the fifth intercostal space anterior axillary line is, which lead we are going to place here? The lead which we are going to place at the fifth intercostal space anterior axillary line. So this is very important question for the quick revision. Okay, so in the fifth intercostal space anterior axillary line, which lead? So that is the lead number 5. So this is we are going to place at the anterior axillary line, fifth intercostal space. Okay, sir, where are other leads we are going to place? Understand here. So this is the lead placement and the most important image for your exam. So here we have the first rib, second rib, third rib, and the fourth rib. So in the fourth intercostal space, okay, in the fourth intercostal space, this is the fourth intercostal space. Okay, this is a right side sternal border. This is the left side sternal border. So here we have the sternum. This is the right sternal border which we have, and this is the left sternal border which we have. Okay, only one lead which we are going to attach at the right side, that is our first lead, that is the V1, which is usually red in the color. Okay, so the red color V1 is the fourth intercostal space. Okay, sir, which side, sir? That is the right side. Sir, where, sir? In the sternal border. Okay, so right sternal border, fourth intercostal space, the V1 we applied. Okay, sir, then dead opposite of that one. So here V2, that is the yellow color, the left sternal border, fourth intercostal space. Okay, so V2 is left, same I told, that is the fourth intercostal space. Also this is same, that is left sternal border. Okay, so this one is the right sternal border. Okay, yes sir. Then after V1 and V2, we are directly going to apply the V4. So that is where, sir? That is in the fifth intercostal space. So this is in the fifth intercostal space. Okay, yes sir. In the fifth intercostal space, where, sir? So we are going to draw an imaginary line on the clavicle. So exact middle of the clavicle, that I am going to come down. So that is the fifth intercostal space, that is the mid clavicular line. I am going to attach the V4. In between the V2 and V4, I am going to apply the V3. Okay, yes, V1 applied, V2 applied, V4 applied, then V3 applied between the V2 and the V4. Okay, yes. Then here we have the anterior portion of the axilla, same in the fifth intercostal space. That is the fifth intercostal space anterior axillary line. So that is fifth intercostal space anterior axillary line. So I am going to apply the V5. Okay, and exactly middle of the axilla, that is same in the fifth intercostal space. Fifth intercostal space, that is mid axillary line. So this is a V6. But in the question what they have asked, where and which, sorry, where not, which lead we are applying in the fifth intercostal space anterior axillary line is the question. So that is the fifth lead we are applying. You can see here. Yes. The lead placed in the fifth intercostal space, anterior axillary line is the V5. So that is the V5. So how many leads we have, sir? So we have the chest 6 leads. Okay, so 6 chest leads we have. Okay, sir, how many limb lead we have, sir? So we have the 3 limb leads. Sir, how many standard leads we have, sir? So we have the 3 standard leads. Okay, yes, sir. So total how many, sir? So total 12 chest leads. Total 12. So not chest leads. Total 12 leads we have. Sir, while taking the ECG, where we have seen, sir, 4 limbs, like the 4 lead will apply to 4 limbs, sir. Yes, the 4 lead we are going to apply to the 4 limb. In that one, the right leg is considered as neutral and this is not counted. Okay, so this is not counted. So 6 chest leads, 6 limb leads, and the 3 limb leads and the 4 standard leads. So this standard leads is the leads imaginarily present in between the our this particular William-Anthony triangle. So I will teach you what is the William-Anthony triangle. So then you will going to understand that one. Okay, yes, sir. So let me teach you what is the William-Anthony triangle. And remember, who is the father of the ECG or who is the founder of the ECG? So the father and founder of the ECG is our William-Anthony. Okay, so he have given one triangle. So that is, consider this is our right leg, the right hand. This is the left hand, and this is the our left foot. Okay, yes, sir. So here we have the right hand, left hand, and the left foot. So here is the right foot. Okay, so I told right foot is the just a neutral lead. We are not going to count that one. Okay, yes, sir. So here from the right hand to the left hand, I am drawing one imaginary line, and from the left hand to the left leg, I am drawing another imaginary line, and from the right hand to the left leg, I am drawing one more imaginary line. Okay, so here this one is the right hand, so I will call this one as the augmented vector right, and this one is the left hand, I will call this one as the augmented vector left, and this one is the augmented vector foot. Okay, yes, sir. This is augmented vector right, augmented vector left, augmented vector foot. And here we have standard lead number 1, standard lead number 2, and standard lead number 3. This is the cycle we are going to follow, not this one. Okay, you don't follow like this. This is the lead cycle you are going to follow. The question will come. The standard lead number 2 is present between. It is present between the augmented vector right and augmented vector foot. We have the standard lead number 2. The standard lead number 3 is present between. That is between the augmented vector left and augmented vector foot. We have the standard lead number 3. Okay, and standard lead number 1, that is between the augmented vector right and augmented vector left. We have the standard lead number 3. So these are the total 6 leads. So that is very importantly 3 limb leads, 3 standard leads, 6 chest leads. Total 12 lead ECG we have. Are you getting the point? Yes. So this triangle which is formed here, this is only we call as the William-Anthony triangle. So what we can call this one? So we call this one as the William-Anthony triangle. So very important, please do keep in your mind. Okay, and which one is neutral here? So that is the right leg is considered as neutral. Okay, yes, sir. The most important. Next comes to the a quick revision of the thing what we have already done. Same thing which is written here. So that is V1 in the 4th intercostal space, right sternal border. V2 that is in the 4th intercostal space, left sternal border, and only one which is there right side, that is our V1. Please do remember. And we have the V3 that is directly between the V2 and V4. So question have been asked in your exam where you are going to apply the V3. That is between the V2 and V4. And we have the 5th, that is the V4, that is in the 5th intercostal space, that is left side mid clavicular line, and the V5 that is the 5th intercostal space, that is left side anterior axillary line. V6 that is 5th intercostal space, left side mid axillary line. So these are the chest leads and its placement, very important for the exam. Please do keep in your mind. Okay, yes sir. Next, which we have here, this one. What is the normal duration of the PR interval? PR interval, not a PR segment. I want the normal duration of the PR interval. So try to put the answer. Normal duration of the PR interval in a healthy adult ECG. So what is the ECG? We have discussed the entire thing about the ECG, right? So the ECG means electrocardiogram, which collects the electrical conductivity of our heart. Okay, it will tells how the electrical conduction is happening in our heart. So that is the main purpose of the electrocardiogram. So getting the point? Yes. So every one of you give the answer. Just I will have the water. Yes. So the answer for this question goes to the, and few of you have given the correct answer, that is the C. 0.12 to 0.20 second. And almost all you people will confuse between the PR segment and PR interval. If the question is asking about the PR segment, that time it will go to the 0.08 to the 0.12 second. Okay, so this is answer of the PR segment. Okay, and this is answer for the PR interval. So this is the answer for the PR interval. Okay, yes, yes sir. Sir, what is the difference between these two, sir? What is the difference between the PR interval and PR segments? Let me explain you that one, so that will be a very easier for you. So here we have the ECG, that is the isovolumetric line we have, then the P wave we have, and then the Q, R, S and T. Okay, so this is we have the ECG. So this is the P wave, which indicates the function of the atrium. Okay, so P wave indicates the function of the atrium. Which function, sir? That is the atrial contraction. What P wave indicates? P wave indicates the atrial contraction. Okay, so next we have the Q wave, sir, and R wave, sir, ES waves. So what actually the QRS complex indicates? This indicates the function of the ventricle, that is the ventricular contraction. Okay, yes sir. Next we have, sir, T wave. So this T wave, which indicates the ventricular relaxation. Only one wave which explains about the relaxation, that is the T wave. So I told P wave about the atrial contraction and QRS complex about the ventricular contraction. Okay, and T wave is the wave which represents the relaxation of the ventricles. Okay, yes sir. So now we were discussing about what is the PR segment and what is the PR interval. So PR segment is the very simple thing which starts with the end of the P wave and which ends with the start of the R wave. So that is PR segment. So this is the our PR segment. Okay, yes sir. But the PR interval, where it will start, sir? PR interval will start at the start of the P wave and it will go until the start of the our R wave. So this is our PR interval. Okay, so PR segment is short, so it takes a short time, so that is only of about 0.08 to the 0.12 second, because this particular PR segment which is there, which will forms in the 2 to 3 small box of the ECG. 2 to 3 small box of the ECG, this particular wave will form. Okay, and here we have a pair interval which forms between the 3 to 5 small box. Okay, so this will starting from the here and ending here. So this will forms in the 3 to 5 small box. Okay, it will forms in the 3 to 5 small box, or we can say 5 balls small box is equal to one big box. One big box. Okay, yes sir. So this is the very frequently people will confuse in the exam. Okay, focus segment is small, interval is infinity, that is the big. Okay, interval is infinity, that is the big. Segment is yes for the small. So small means that is only in the 2 to 3 box, and the big means that is the interval. So that is the 3 to 5 small box. Okay, remember. So here is the a very important and beautiful information for you all. So that is how we are going to measure the small box and big box, and how much time it actually takes, and the various ECG components and how much time it will take. This is not only important, this is the very important. Okay, yes. So let me teach you this one, right? Yes. First we have here a box. This is the one big box. So what is this one, sir? This one is the one big box we have from the ECG graph. So in this one big box of the ECG graph, so inside we have the 5 small box. One big box is having the 5 small box. 1, 2, 3, 4, and the 5. Yes, one big box is having how many small box? One big box is equal to 5 small box. Okay, so here this one, from starting of the one small box to the end of the one small box, if ECG paper wants to move, means it requires 0.04 second. To cross the one small box, how much time required for the ECG machine? It requires 0.04 second. Okay, so to cross the one small box, the ECG requiring the 0.04 second, which means again here the 0.04 second, 0.04 second, 0.04 second, 0.04 second. So total to cross the one big box, it requires the 0.20 second. If you want, you can multiply 0.04 into the 5. So this becomes the 0.20 second. The question is, how much time taken by the ECG machine to cross the one small box? The answer is, I want answer from every one of you. So how much time is taken by the ECG machine to cross the one small box? That is 0.04 second. Well done. Okay, and here we have the 5 small box in the one big box. Okay, we have the how many small box in the one big box? We have the 1, 2, 3, 4, and the 5. So to cross the one big box, how much time is required? Yes, to cross the one big box, how much time is required? So time required to cross the one big box is 0.20 second. Getting the point? Yes, sir. So what is the amplitude of the one small box? Amplitude of the one small box, that is the 0.5 millivolt, we can say, or we can say 5 mm. Okay, so this is the amplitude of the our one small box. Okay, yes. So now you tell me in 1 second how much mm the ECG machine will run. So in 1 second it will run about the 25 mm per second will be the speed of the ECG machine. So per second how much it will run the paper? So it will run the paper per second 25 mm of the paper will be run under the ECG machine. So that is the 25 mm per second is the speed. Okay, so please do keep in mind, right? Yes. So I told one big box is equal to 5 small box, and in 1 second it will run around of the 25 mm, and in 1 minute it will crosses the 300 big box. It will crosses the 300 big box, and in 1 minute same it will crosses the 300 big box, in the sense 1500 small box it will crosses. Okay, so 500 small box also it will crosses. Okay, so 300 big box in the sense, in a one big box we have the 5 small box. Okay, so 300 big box in the sense it is equal to the 1500 small box. Getting the point? Yes sir. If it is running per second 25 mm, in 1 minute it will cross the 300 big box and 1500 small box. This is very important. Okay, yes sir. So one small box, time taken to cross the one small box is the 0.04 second, and so the in one small box in the sense one small box 0.04 second means to cross the one big box, that is the 5 small box which we have, that is 0.04 into 5, that is the 0.20 second. So this is the time to cross the one big box. Okay, so this is the time taken to cross one big box. Okay, so that is the 0.20 second. And what I told to you all, so that is our PR segment will form in the 2 to 3 small box. So consider from here to the, I will take the different pen here. So this is the starting of the small box and here it is ended. Okay, 2 to 3 small box I told. So one small box 0.04 second, 0.04, that is 0.08 second, and this is the 0.12 second, right? So the range will be for the PR segment, that is the 0.08 to the 0.12 second will be taken by the our PR segment. Okay, PR interval I told it will be from the 3 to 5. So 3 to 5 in the sense from here to the here. Okay, so one big box is equal to 0.20 second. Okay, 3 in the sense that is 0.12 second. So the time taken for the PR interval will be, that is the 0.12 second to 0.20 second, because the PR interval will be formed in, so in the 3 to 5 small box. Okay, so 3 to 5 small box is required. So the time is required for this much. This is for the interval, that is the our PR interval. Okay, yes sir. So that is I told for the PR segment, so that is already we have written. Okay, so I don't want to repeat it again, so because we have written it already here, right? You can see, right? So now you revise this one. What I told here, measurement, one small square or the one small box is forcing in a 0.04 second, which means one large square, that is the 5 mm amplitude which is having, so that is the 0.20 seconds. So sorry, here the small mistake. This is the one small box is equal to 0.1 millivolt amplitude. Okay, and from here to here the one big box is equal to, that is the 0.5 millivolt amplitude or the 5 mm amplitude. Okay, so I told it for one small box, that is, please do correct, one small box is equal to 0.1 millivolt or the 1 mm, and 5 small box is equal to 0.5 millivolt or the 5 mm. Okay, yes, so this one you please do remember, right? So here we have the time taken for the big box is the our 0.20 seconds. So right, yes. Next, which comes to the a P wave which forms in the 2 to 3 small box, QRS complex which forms in the 2 to 3 small box, and PR segment which cross in the 2 to 3 small box. So 2 small box means 0.08 second and 3 small box means 0.12 second. So if the question is coming time taken by the P wave, QRS complex and the PR interval, that is the 2 to 3 small boxes are the 0.08 to the 0.12 second. And next comes to the our PR interval. So PR interval, how much time it is taking, sir? So this one is taking a one big box, big square. So that is a 3 to 5 small square, we can say, that is 3 small square is the 0.12 second and the 5 small square is the 0.20 second. And this is what actually asked when the question. Okay, and comes to the QT interval. In the QT interval, so this is taking the 2 big square. So that is the 2 big square means one big square is the 0.20 second. Similarly, two big square is double of that one. That is the 0.40 second. So this is the very important for our exam. So from here we may expect one question directly in the exam. Okay. So here the question is about the PR interval. Okay. So let me see the question. So that is about the PR interval. So answer will go to the 0.02 to the 0.12 to the 0.20 second. Okay. So I hope it is clear to every one of you. Right. Then the next which we have is this question. Yes. A very important question. In ACG, two large squares are observed between the two consecutive R waves. Okay. So here we have the one R wave, another R wave, another R wave, another R wave. So between the two R waves, we have the two large boxes. Okay, we can see also here. We can see here. This is one large box which we have. Another large box which we have. So in one large box, how many small boxes are? So in one large box, how many small boxes? Total 5 small boxes. Right? Yes, sir. So between the two RR consecutive waves, how many small large box we have? So total we have the two large box. Two large box. Okay. Yes, sir. So it means we have the 10 small box. Okay. So how many 10 small box we have? The two large box in the sense 10 small box. Okay. So very simple question. Two large squares are observed between the two consecutive R waves. Using the 300 method, what is the heart rate of this ACC? So the image which is given here, so you have to calculate and tell the heart rate of this ACC. So how we are going to calculate and tell the heart rate of this ACC? Very simple. So I told for 1 minute, how many large boxes are crossing under the ACC? I told for 1 second, 25 mm. Okay, so that is the 25 mm per second is the speed of the ECG, means it will crosses 300 big box per minute. So it means 1500, 300 big box is equal to 1500 small box. Okay, so 1500 small box per minute it will cross. Okay, so the standard speed of the ECG is 25 mm per second. So it is crossing the 300 big box per minute, right? So that is the reason we are going to keep here the 300, because heart rate, how we are calculating? We are calculating this much per minute. That is the 60 beats per minute, 70 beat per minute, 80 beat per minute. So here also we are going to check. So that is the number of the big boxes per minute which is crossing is the 300. Okay, so that is the 300. Right? So just we are going to divide this one. That is the R. So that is number of big boxes or the big square between the two consecutive R waves. So between the two consecutive R waves. So here one R wave, one big square, second big square. One big square, second big square. 1, 2, 1, 2. So we have a two big square. So you can see that is very simple. The 300 divided by 2, which is equal to 150. Right? So 150 is the heart rate of this particular ECG. Okay. So when the gap between the R wave is less, the heart rate will be more. When the gap between the R wave is more, the heart rate will be less. Okay, so this is very important. Please do keep in your mind. Okay, yes. So now you can see this one and you can mention the answer for this one. Okay, so this is also having the same. That is the between the two R waves. So how many boxes we are having? This is one R wave. This is another R wave. So again 1 and 2. So this is also, yes, the 300 divided by a large box between the two R waves, that is the 2. This is going to give again 150 beats per minute. Okay, yes. So they can ask you by the small boxes also. So when they will ask you regarding the small boxes, that is the formula will change. Okay, So for 1 minute 300 big boxes are crossing means for 1 minute 1500 small boxes are crossing. So 1500 divided by the number of number of small box between the RR waves I am going to count. Okay. So here the two big boxes are there means how many small box we are having? So that is 1500 divided by 10 small boxes, because one big box is equal to 5 small box. Okay, so 2 big box is equal to 10 small box. So 10 1 is 10 and 10 150 is a, so that is 1500. So how much it came here? So it came here is the 150 beats per minute. So both will come same. Okay, so both will come same. I hope it is very much clear. If the small box is the question, 1500 divided by the number of the small box between the RR wave is the formula. If the big box is the question, so 300 divided by the number of the big boxes between the two RR waves is the how we are going to capture and answer here. Okay, yes. So this is what we have discussed already. So to calculate the big boxes count, okay, so calculated through the big boxes count means 300 divided by the number of the big boxes. Okay, so between the RR waves, and to calculate it by the small box means there is 1500 divided by the number of the small boxes between the two RR waves. So this is the formula. So I hope it is very much clear. Okay, it's so now try to give the best answer to this question. Which rhythm is most likely shown in this particular image? Option A we have, that is ventricular tachycardia. B we have is the atrial flutter, and C we have is the atrial fibrillation. Then D we have is the ventricular fibrillation. What is your answer? Yes, what is your answer? So Padafat, do mention your answer here. Padafat, do mention your answer here. Padafat, everyone. We don't have much time. I want answer from the everyone of you. Done. So analyze it. Did you guys analyze this one? Yes. So atrial flutter fibrillation is the confusion. So let me clear this one first. Okay. So whenever you are suspecting the ventricular problem, first you see at the our QRS complex. You see in all the QRS complex, which are very perfect. So there is properly Q is there, R is there, S is there, Q is there, R is there, S is there. So there is no problem with the QRS complex. Means it is not a ventricular problem. It is a problem. You can see here also there is in the problem in the P wave. It is abnormally anyhow it came, and here we have the abnormal. Here we have the abnormal. Here we have the abnormal. Okay, you can see this much abnormal, this much abnormal. Okay, so it means the problem is in the P wave. So what I told, P wave represents the atrial contraction. Okay, so something which is problem in the P wave, which means the problem is there in the atrium. Something which is problem in the QRS complex means the problem is there in the ventricles. This is the basic thing we just have to understand here. Okay, yes sir. Something which is problem in the atrium, so the QRS complex is normal means this is not in the ventricular tachycardia, this is not in the ventricular fibrillation. Okay, so I'm eliminating the two options. Now the confusion is there between the atrial flutter and the atrial fibrillation. So in the flutter, we will get the classical ECG like this one. Okay, so this one. Like, okay, so we will be getting the P wave like a sawtooth appearance. That is the flutter. So that is the flutter. Here you can see, Here is the one completely abnormal P wave. Here is the inorganized P wave. Here is the completely inorganized. So that is a fibrillation. Okay, so the atrial fibrillation is the answer, not the flutter. Okay, so I am going to show you the atrial flutter image also. Just relax. Okay, so this answer goes to the option C. So that is the our atrial fibrillation. Okay, so that is completely like this. Inorganized PO. So completely inorganized PO is there. So that is the atrial fibrillation goes to the answer. Getting the point? Yes. So next you can see here the atrial flutter. So how beautiful it is there. You can see properly organized. So that is here it is eliminated. Come. So this is like a tooth. Here also it is like a tooth. Here also it is like a tooth. Getting the point? So it is the like a tooth. So this is the sawtooth appearance. This is the atrial flutter. So this is the tooth. So this is what we can say as the sawtooth appearance. That is the characteristics of the our atrial flutter. So that is the atrial flutter. Getting the point? Yes, sir. So now this image. What is this image? This image is the Torsades depointis or the polymorphic ventricular T. So how we are going to say this is the polymorphic ventricular tachycardia or the Torsades depointis? That is very simple. The word itself it is saying this is the polymorphic. Means more than two morphologies or more than one morphology is there. See here the QRS complex, here is the different, here is the different, here is the difference. So we are getting the more than three types of QRS complex. QRS complex. That is more than three types. We call this one as the Torsades depointis. Torsades depointis. Yes. So this is the image-based question of the Torsades depointis or the polymorphic ventricular tachycardia. So that's more than three types of the QRS complex we are getting. Just I'm giving the clues and the golden points. That's it. So if you want to study the entire ECG, there are the three beautiful classes properly. Each and every image, complete basic, complete basic, full basic to full advanced, complete advanced. Everything which you want to know about the ECG, there are the three separate classes are there. Visit the Play Store, check the ECG classes, watch the three classes. You become a next version and pro version of the your ECG. When someone you give the ECG in your hand, so in a second you will interpret and you will throw the ECG paper like this. So that kind of the knowledge you will get. So if you watch all the three videos, okay, so that is much necessary for the understanding from the very basic to advanced. This is here I am teaching completely in a view of the competitive exam. So there where you will be getting the more important thing only I am going to teach you here. Okay, so the thing which is having the high chance in the striking exam, so that is covering here. Okay, if you want to know the from very basic to very advanced, visit the Play Store, download the MNC app, and you can watch through the app also, and you can visit the playlist and watch through the our ECG YouTube classes also. That is very properly organized. Okay, yes, here we have the Torsades depointis. Next question is, what is the drug of choice for the Torsades depointis? What is the drug of choice for the Torsades depointis? Tell me the answer. What is the actually and a very important drug of choice for the Torsades depointis? Most importantly, remember the drug of choice for the Torsades depointis is injection MgSO4. That's the magnesium sulfate. This is the drug of choice for the Torsades depointis. Please do remember previously asked question, and there is maybe a chance of striking the question again. Yes, this magnesium sulfate only we are going to treat in the eclampsia in the pregnancy, severe preeclampsia of the pregnancy. Yes, the same magnesium sulfate which we are giving here as a drug of choice in the Torsades depointis. Please do remember. Okay, yes. And here you can see the ventricular tachycardia image. So ventricular tachycardia and ventricular fibrillation, you can differentiate very easily. So I have made the both side by side. Okay. So ventricular tachycardia is just an organized way of the fast QRS complex we have. So like this. This is the ventricular tachycardia, right? So how will be the ventricular fibrillation, sir? It is like a MAD. It is like a MAD. You can see this is the ventricular fibrillation, right? So this is like a MAD, like anything. So this is the our ventricular fibrillation. You can see here, this is like a MAD. That is our ventricular fibrillation. How we are going to identify? Okay, with the image. So just I am teaching the image based questions here. The ventricular fibrillation you can see here, and ventricular tachycardia you can see. Okay, so this is completely a fast heart rate in a particular point perfect manner, and this is the only heart is shaking here, so there is no contraction. So here there is the ventricular fibrillation here. Okay, yes. So this is very important for the exam. Please do keep in your mind, and from here you may expect a question in your exam. So the next question is, in WPW syndrome, what is the usual effect of the usage? Okay, so in WPW syndrome, what is the usual effect on the ECG? So you are taking the electrocardiography in the WPW syndrome. So how you are going to determine this one? Yes, what is your answer? Remember, the WPW syndrome, that is the Wolff-Parkinson-White syndrome. In the Wolff-Parkinson-White syndrome, we are getting the classical three findings of the usage. So that is the QRS, one thing. Okay, and another one is the PR problem. Another one is the this one, that is the delta wave. So you can see here, the QRS is this much length, PR is this much only small. Okay, so how we have to remember? QRS is broad, or we can say QRS is wide. Wide QRS complex we have, and PR is small, right? So only two ways, two letters. Okay, so that is the small. So we can say small or the short PR interval, and the delta wave is positive. So that is the we have here delta wave. So this is the delta wave, that is the we can say positive delta wave. Okay, so this is most important. QRS is broad or the wide, PR is short, and the delta wave is wide. Okay, so you search for this one and choose your answer. So I told the tricks to remember also in the exams, because you should not get confused in the exam. Okay, so if you are studying here, that will be useful in the exam. So that is the main purpose, right? So wide QRS complex, QRX is wide here, delta wave is positive, and PR is short. So this is about Wolff-Parkinson-White syndrome classical ECG finding. So this is you have to remember. Okay, yes. And here it comes to the next very important assignment question for the tomorrow's class. Okay, this is for your assignment question, so try to not answer here, so people will get confused. So this is the assignment question for you all for the tomorrow's class. Okay, yes, we have done lots of the thing in the today's class, so that was much necessary for our future exams. So I want every one of you to read this particular notes which you are getting in the plan A1 and A2, and remember, today we have the All India Sunday free test. Today we have the All India Sunday free test for all the champions who are attending the upcoming Norcet 10, so that you can assess yourself and your level of the preparation, and you encourage your friend to attend the test, and you people can just not compare of the score, so just to compare your level of the preparation. If your friend is scoring less, boost him, help him, and lift up him, so you both can join the same aims. Okay, you both can stay in the same room, so your room rent also will be going to save, right? Yes. So who all are studying in the library, who all are there in the Hubli Dharwad, so I know you people really working hard. Don't take a back step now. The step now you are keeping forward is a step which is going to change your life. ಜೀವನದಾಗ ಎಲ್ಲ ಮುಗಿತು ಅಂದಾಗ ಇನ್ನೊಂದು ಸ್ಟೆಪ್ ಮುಂದೆ ಇಡೋದು ಕಲ್ತ್ಕೋರಿ ಜೀವನದಾಗ. ಅವಾಗ ನಿಮ್ಮ ಭಾಗ್ಯದ ಬಾಗಿಲು ತೆರೆದು ಬಿಡುತ್ತೆ. ಓಕೆ, ಸೊ ಎಲ್ಲಾ ಮುಗೀತು ಏನೂ ಆಗಕ್ಕಿಲ್ಲ ಅಂದಾಗ ಧೈರ್ಯ ಮಾಡ್ರಿ, ಇನ್ನೊಂದ್ ಸ್ಟೆಪ್ ಮುಂದಿಡ್ರಿ, ಅವಾಗ ನಿಮ್ ಸಕ್ಸಸ್ ಕ್ರಿಯೇಟ್ ಆಗುತ್ತೆ. ಹಾ, ಸೊ ಎಲ್ಲ ಕಂಫರ್ಟ್ ಝೋನ್ ಇದ್ದಾಗ ಬರ್ಬೇಕಂದ್ರೆ ಬಹಳ ಡಿಫಿಕಲ್ಟ್ ಇರುತ್ತೆ. ಸೊ ಡಿಫಿಕಲ್ಟ್ ಫೇಸ್ ಮಾಡೋನು ಇವತ್ತು ಹಿಸ್ಟ್ರಿ ಬರೀತಾನೆ, ರೈಟ್? ಸೊ ಹಿಸ್ಟ್ರಿ ಬರೆಯೋದನ್ನ ಕಲೀರಿ, ಫೇಸ್ ಮಾಡ್ರಿ ಡಿಫಿಕಲ್ಟೀಸ್ ಆರ್ ದೇರ್ ಟು ಫೇಸ್, ಅಂಡ್ ಡಿಫಿಕಲ್ಟೀಸ್ ವಿಲ್ ಕಮ್ಸ್ ಟು ದಿ ಚಾಂಪಿಯನ್ಸ್ ಓನ್ಲಿ, ನಾಟ್ ಟು ದಿ people who are satisfied in their own life. Okay, so you are trying for something big, so you will get some difficulties. So how you will come out of that difficulty, that defines your championship. Okay, so be confident, and so whenever you will feel everything is end, so that time you take one step forward, so that step only is going to change your life. Okay, so nothing will be end until you finish that one. So try to finish it in your style, so that is the champion style, that is the ranker style. Okay, yes, don't forget to attend the today's all India level Sunday free test. So it is free for everyone, so the link is there in the description box. Join now the master nursing classes app and give the free test. Okay, so thank you so much for watching the video till here. Bye bye, take care. We will meet again with a full energy and the very full energy tomorrow's class again. So tab tak ke liye jai hind, jai bharat. If any difficulties, don't fear, your master is here. Text me in the WhatsApp, I will try from my side to help you all. Okay, so good luck, keep preparing, work hard, so that is going to be helpful, right? Bye bye, take care. Thank you so much.